Hey Rebels, welcome to Rebelcast, your go-to source for the latest in knowledge translation of medical research. Marco Percy here. Thanks for tuning in. Be sure to subscribe to the podcast and follow the team on social media to keep up with the latest content. And today we're diving into a hot topic, ketamine or etomidate for induction during rapid sequence intubation. So let's get into it. For decades, we've debated which induction agent is best for RSI. And we've mostly settled on two agents, ketamine and etomidate. Now, critics of etomidate are going to highlight its link to adrenal suppression. Critics of ketamine, they're going to highlight its association with post-intubation hypotension. Despite lots of literature, the best choice still remains a point of contention. We're going to focus on a new piece of research today that sheds light and informs this debate. It was a recent Bayesian meta-analysis published in Critical Care in February 2024. The authors, Kuroki, Kotani, Yaguchi et al., they asked the question, in adult critically ill patients requiring tracheal intubation, does ketamine, compared to any other agent, reduce mortality at the longest follow-up available? They concluded with a moderate probability that induction with ketamine compared to etomidate was associated with a reduced risk of mortality. The meta-analysis included 8 trials and nearly 3,000 critically ill adults. And they used Bayesian inference. They found that with an 83.2% probability that ketamine likely reduced mortality compared to etomidate. Now, this is a compelling finding. It definitely sparks some new conversations, and maybe it even swings the pendulum in favor of ketamine. Let's get on to it. The meta-analysis primarily included patients with sepsis. Now, other conditions such as COPD, heart failure, brain bleeds, these were all underrepresented in this particular trial. The two largest trials that informed the meta-analysis, the Ketamine trial, included only 22% trauma patients, and the EVK trial included 7% trauma patients. Another paper by Driver also included trauma patients, but it's not yet published, so we don't have specific demographic information on how many trauma patients were actually included. Most other papers included no trauma patients at all. Why include all critically ill patients in a meta-analysis? Excluding the search to only septic patients makes it a bit harder to find papers for inclusion and also likely to have much smaller sample sizes. Including a broader group of patients makes the search for studies to include in the meta-analysis a bit easier, and it increases the chances of actually finding meaningful data. This complicates the interpretation of the data because the resulting information becomes less specific to any single clinical situation. Now, there are also some key considerations that we got to talk about regarding the outcomes. 4 of 8 trials collected data on 28-day mortality. A 5th trial collected 30-day mortality. The remaining 3 trials collected mortality rates at hospital discharge. For example, if we look at the POWER study from 2021, this study focused on hemodynamic effects of the induction agents, and they measured outcomes, including mortality, at 24 hours. Do induction agents even impact 28-day or 30-day mortality? It's hard to believe that a single dose of an induction agent could impact all-cause mortality 1 month out. The shorter half-life of induction agents would intuitively suggest a short-term impact, if any. So maybe a 24 or 48-hour mortality outcome is a reasonable one. Either way, there's a big difference between 24-hour mortality and 28-day mortality. And this raises questions about incorporating short-term outcomes in the meta-analysis alongside other trials with far longer outcomes. Now let's get into heterogeneity. When analyzing meta-analyses, it's important to understand the different types of heterogeneity. Statistical heterogeneity in meta-analysis refers to the variability in study outcomes that we cannot link to chance alone. Now think of your tau squared, your chi squared, your I squared. These are statistical measures of heterogeneity, and they can be found at the bottom of a forest plot, which you find in almost every meta-analysis. In this study, statistical heterogeneity was relatively low in both the Bayesian analysis and the frequentist analysis. Let's move on to methodologic heterogeneity. This refers to variations in design and the quality of the included studies. 7 of 8 trials were RCTs. 1 trial was a propensity match study. 7 of 8 trials were rated as relatively low risk. 1 RCT had some cause for concern. So there was relatively little methodologic variation in this meta-analysis. But if they had included papers with weak methodologies, this is going to bias the results and the overall findings of our meta-analysis. Let's move on to clinical heterogeneity. Studies that may be conceptually similar, but the patients could have drastically different populations. That's what clinical heterogeneity means. Now, this would be apparent when there is a clear difference in the pathophysiologic basis for disease. Consider the pathophysiology of trauma patients who need intubation. This is likely going to be drastically different from patients with septic shock and COPD. So combining data from patients with dramatically different conditions into a single analysis might mask important differences in how these patients are going to respond to different induction agents, and it might actually limit the usefulness of the resulting data. Authors should explain clinical heterogeneity in the data with subgroup analysis. This can help identify areas where patients might respond differently based on one specific disease process or another. The authors performed a subgroup analysis on only RCTs and another eliminating trials at high risk of bias. But it would have been more helpful if they did an additional subgroup analysis on the reason for intubation or the ultimate diagnosis. Let's move on to Bayesian interpretation of this meta-analysis. The investigators found an 83.2% probability that ketamine reduces mortality compared to etomidate. But what does this mean in clinical practice? Should these results sway our choice of induction agents in our next patient? When the authors looked at only RCTs and eliminated the one propensity match study in the paper, the number actually shrinks to 68%, which is still a pretty big difference. If we look at the 95% credible interval, it's going to be similar to our 95% confidence interval. That number actually crosses 1. And that means that there's no statistically significant difference between these two groups. Bayesian statistics offer a probability-based perspective to the data. And they answer the question, what is the probability of the hypothesis given the measured data? If we look at frequentist statistics, they use confidence intervals and p-values, and they require that we either accept or reject a null hypothesis based on data which we have measured in the paper. But they may not capture the complexity of real-world medical decision-making. Frequentist statistics are helpful when there's little or no uncertainty and there's a clear answer. Think of chess. However, physicians regularly make clinical decisions in situations with hidden or missing information, more like poker. But with a posterior probability of more than 83% that ketamine is superior, some might argue that we don't need more studies and we should just embrace ketamine for all. Finding a statistically significant mortality benefit based on a single treatment in all critically ill patients is extremely difficult. It would require an enormous sample size. So this meta-analysis suggests that ketamine may be a better induction agent than etomidate, but the patient population was too heterogeneous to make a blanket statement about all critically ill patients. We really need large international multi-center randomized control trials in specific disease subsets to identify which patients might benefit from ketamine and which patients might benefit from etomidate. So the debate on whether to use ketamine or etomidate as an induction agent will continue despite this new study. For more insights into the ever-evolving world of healthcare, subscribe to our podcast on your favorite listening platform. Thanks for listening.